Thank you for the nice introduction, Nisha. Thanks, Tenda. Colleagues and friends, I'm Desiree Wussler from Cardiovascular Research Institute in Basel, and I'm part of Christian's research group for several years now, and I'm also a resident for internal medicine and cardiology at the University Hospital in Basel. I'm very happy to be part of this meeting this year, and I welcome to you my presentation about the comprehensive vasodilation harms women with acute heart failure, novel insights from our galactic randomized trial. As indicated by my picture on the first slide, I will not start directly with acute heart failure, but with another passion of mine. So it's not working? Yes. Thank you. So this other passion is mountains, and I want to ask you a question. Any ideas which mountain this is? So I might give you some hints. It's in Nepal, and it's an 8,000 meter summit. Everest, okay, that's right. So this leads us back in turn to acute heart failure and the question, what do the highest mountain on Earth and acute heart failure have in common? So the first point is quite obvious. It's danger. Both of them are quite dangerous. So if it comes to the Everest, it always depends on the season, but if it's a really bad season for the alpinists, one successful summit attempt is demanded by 10 deaths. And if it comes to acute heart failure, we see in several trials that the one-year mortality rate is between 20 and 25%. Another common feature I want to talk about is sex-specific, is underrepresentation of women, both on the Everest and also in acute heart failure trials. So in many of the trials which are guideline relevant, only 20 to 25% are female. But in this case, we're even doing better than up here because only 9% of successful summit attempts on the Everest are done by women. So after this little excursion to the Everest, I will continue with these sex-specific differences in acute heart failure. So if it comes to the heart failure phenotype, heart failure with preserved ejection fraction is much more common in women, whereas heart failure with reduced ejection fraction is more common in men. In addition, differences in body composition, such as a higher percentage of body fat in women, can lead to differences between pharmacokinetics and pharmacodynamics of applied drug, and this could also result in a sex-specific drug effect. Despite this new evidence, physicians still apply a uniform therapeutic approach in patients with acute heart failure. So, as these sex-specific differences in heart failure are both very important and also under-recognized, it's really of interest to further characterize these differences and also to analyze the risk-benefit ratio of novel therapies individually in women and men. And therefore, we performed a sex-specific analysis of the galactic randomized trial. It's the largest investigator-initiated randomized trial in acute heart failure, and it investigated a novel strategy of early, intensive, and sustained vasodilation in a broader acute heart failure population. As you can see here in this Kaplan-Meier curve of the first galactic publication in JAMA, the study overall provided a comparable outcome between this group of intensive vasodilation and usual care. Regarding our following analysis, I already said Galactic is an investigator-initiated, multi-center randomized trial, and patients were either randomized to the strategy of early intensive vasodilation or to usual care throughout the hospitalization. So patients were included if they presented with acute heart failure to the emergency department with a plan for treatment in a general ward. And exclusion criteria were a blood pressure at presentation which was lower than 100 millimeters of mercury, and also severe renal dysfunction with a creatinine greater than 250 micromoles per liter. So just to shortly summarize this strategy of the vasodilation, you see here that we started from hospital admission on, and this strategy consisted of 3 different drugs. It was nitro, which was given sublingual and also transdermal, and first increased and then decreased again. And we also established hydralazine, which was given for 48 hours. And from day 2 on, we started with a rapid uptitration of either an ACE inhibitor, an angiotensin receptor blocker, or sacubitril valsartan. So the primary endpoint of the Galactic study was a combined one. It was a composite endpoint of acute heart failure rehospitalization and all-cause mortality at 180 days. And this subgroup analysis was pre-specified according to sex. We included about 780 patients. Of these, about 290 were women and 490 were men. And the women were significantly older, they had a lower body weight, and they more often suffered from hypertensive heart failure with preserved ejection fraction. In contrast, the men more often had a history of myocardial infarction, and they more often had this typical cardiovascular risk factors like smoking. And in addition, they more often suffered from heart failure with reduced ejection fraction and ischemic heart disease. Regarding the combined endpoint, we found a statistically significant interaction of sex and this treatment strategy. And therefore, we characterized and analyzed the primary endpoint individually in women and men. And what you can see here in the Kaplan-Meier curve in red are the women, and the vasodilation group is marked by the solid line, and the usual care group is the dashed line. And you see that there's a big difference in the primary endpoint because the women randomized to vasodilation had a really higher proportion of this event compared to usual care. And this difference was also statistically significant in an adjusted hazard ratio analysis in the Cox regression model. In addition, we see this curve here for men, and we see that in men there's a tendency for the other way around. So men randomized to usual care had a trend to experience the combined endpoint more often in comparison to women. However, this difference was not statistically significant in an adjusted hazard ratio analysis. So we performed secondary analysis which could possibly explain this finding. So the first finding was this harmful effect of the vasodilation strategy in women. We saw that women had a lower body weight in comparison to men, but they still received similar doses of hydralazine and also nitro, which could result in a toxic effect. And this can be probably explained by the finding that women had a prolonged index hospitalization due to adverse event already happened in the hospital. The second finding was this trend for benefit of the vasodilation strategy in men, and a possible explanation for that is that the uptitration of an ACE inhibitor was more successful in men compared to women, and also according to guidelines and earlier studies, we would expect that in this population of heart failure with reduced ejection fraction and also ischemic heart disease, a high dose of an ACE inhibitor would have a beneficial effect. Some limitations of this study: we cannot generalize our findings to patients with severe renal dysfunction and also to patients with a systolic blood pressure lower than 100 millimeters of mercury at presentation, because we excluded these patients from the beginning. In addition, we know that the subgroup analysis has lower statistical power. However, the statistically significant result of our subgroup analysis is also present. To conclude the study, as in several earlier trials, we saw this sex-specific heart failure phenotypes, and we also saw that this comprehensive vasodilation strategy harmed women with acute heart failure, and this possibly leads to a need for a sex-specific therapy approach in acute heart failure. So as the upcoming soccer match is luckily not going to take place in high-altitude conditions, I'm sure that there will be no shortness of breath in our great galactic team. And I thank you for your attention, and I'm open for your questions.
Thank you very much, Desiree, for this very interesting study and results. Here is the first question.
Thanks very much. I was always hoping that Christian would publish the trial would have been positive initially, but I have a question. How long did therapy, the up-titration of the oral therapies occur? Was it just during the inpatient stay?
Yes, so it was started when the patient presented to the ED, and then according to the strategy, it was performed until the discharge of the ward.
It's interesting because your curves are actually the opposite the first 30 days. It looks actually beneficial in women for the first 30 days, which would probably be most related to inpatient therapy. And then after 30 days, when they see their primary care doctor or cardiologist and get other medications adjusted, that's it looked like when the harm occurred. So I wonder if your message is actually vasodilation is more beneficial in women. What happens to them after 30 days is what's in question, right? I mean, your curves are completely opposite. I wouldn't expect if you stopped the therapy at day 8 of hospital discharge that it would impact them at day 60, but it could impact them through day 30. So I wonder if your message could perhaps be the opposite.
Okay, thank you for this comment.
Yeah, I have a similar point, is that the definition of acute heart failure, I don't think is 180 days. I look at this as the first 30 days as max. And if you look at your Kaplan-Meier curves, they are on top of each other for the first week, and it's so long I couldn't tell exactly. But I think that the term acute is done after a week or two, because you're no longer acute heart failure at this point. You got a diagnosis, you're on chronic medicines, and so I don't disagree with your conclusions, but I think it's just chronic heart failure at that point. And there does appear to be a difference in women, and that's fine, but I think the terms need to be examined.
Yeah, thank you for this comment.
The front for...
Yes. Did you analyze if there was any relationship with the effect with systolic blood pressure? Because we believe that vasodilators may have a role regardless the sex or the gender, in acute heart failure in very hypertensive patients. And did you analyze if there was a different effect regarding the systolic blood pressure?
You mean a different systolic blood pressure at presentation, or what do you mean?
Presentation, yes.
So between...
Sorry, because we try to use a higher level of vasodilators, intravenous or some other way in clinical practice to decrease very high systolic blood pressure, and this seems that can have an effect, a positive effect, which is different when you give transdermal and progressive vasodilator in patients with normal systolic blood pressure. It would be a completely different scenario.
So overall, these baseline characteristics were really well balanced in the study, and the blood pressure at admission, the systolic blood pressure, was about 135 millimeters of mercury in the whole population, so they were not, it's a median. I mean, there were several patients who had a higher blood pressure, but in the median it was about 130, 135, and it was really well balanced. But we saw a trend that the women who were randomized to the vasodilation strategy later, they had a little bit lower blood pressure compared to the women who were like on the usual care. But this was only kind of a trend.
Any other questions? Thank you very much. We go to the next session.